Okay, good morning. We're going to get started. Welcome to Wednesday morning cardiology rounds. It's my pleasure this morning to introduce our own Dr. Hassan Mir. He's kindly agreed to present rounds this morning. Hassan is a cardiologist and researcher in our division, and assistant professor of medicine at the University of Ottawa, and he's currently the director of the hypertension program at UOHI. He completed his medical school training at the University of Western Ontario and internal medicine at McMaster, and then did fellowship training in advanced echocardiography and cardiovascular prevention and rehab at UHN in Toronto. So he has a strong interest in clinical research related to digital health and cardiovascular prevention. And he has received over $2 million in peer-reviewed grant funding and is actively leading several randomized controlled trials in cardiovascular prevention, focusing on improving care in hypertension. So welcome so much, Hassan, and we look forward to your presentation this morning.
All right. Thanks so much for that introduction, and thanks for those that have joined to learn about this exciting area of hypertension at 7:30 in the morning. And I'm sure what I'm going to be presenting is going to be more or less review for you, so I do really appreciate you joining. I did sprinkle in some of the newer topics of discussion that hopefully we can have a conversation about. This is not meant to be kind of like a 60-minute or 59-minute session, although I guess I can sometimes go off on tangents and maybe we'll get there. But please welcome any questions. And of course, this is something that I'm sure we have a lot of expertise in our room as well. So in terms of disclosures specifically related to hypertension, no particular industry type of partnerships, but I have received a few grants related to providing hypertension care as well, or research relating to hypertension. So in terms of the objectives, and again, one of the things that you're not going to see here is you're not going to see lots of beautiful pictures and you're not going to see lots of beautiful videos and transitions, because I like to keep things simple. That's just kind of how I was taught coming through the ranks in Hamilton. And so just getting right to the point, we're going to talk a little bit about the background of hypertension, the epidemiology, the diagnosis, which is going to be certainly a review, although I have to admit I'm guilty of not following all of the things that I'm going to be telling you that we should be doing. Treatment, optimal targets, resistant hypertension, and then some of the information about our local initiatives and research that's occurring. So I think all of us appreciate that hypertension is an extremely important risk factor, and it pains me to say this given my role in smoking cessation, but as a overall risk factor for the general population, hypertension is actually the most important risk factor for development of cardiovascular disease. Of course, those that smoke, that a little bit of different discussion, but general population, hypertension is the most important risk factor. And it's something that is not just unique to us in high-income countries or in the developed world. Globally, there is approximately 1 billion to 1.5 billion people that are affected by hypertension, which is approximately 1 in 4 people. So not just about the people that we're going to be looking after, but us ourselves are going to develop hypertension. It's just a matter of time, right? That's just what's going to happen. We have to live with it and manage it. It is a leading cause of morbidity and mortality. Again, we all understand the risks of it associated with heart attack, stroke, death, dementia, chronic kidney disease, you name it, right? So anything that's at the end of those pipes that's getting way too much pressure, that's going to get damaged, hypertension is going to make that worse. The sad reality in this case is, unlike in other situations where you walk into the door and you can immediately see the nicotine staining on the beard and the hand and the smell of cigarettes, you can't easily diagnose this without somebody actively checking your blood pressure. So it's often asymptomatic and often found incidentally, and who knows how long somebody's been living with that hypertension. What worries me, especially, and off on a little bit of a tangent, what worries me in this day and age, especially as we're running into this issue of shortages of family physicians in primary care, is that this is going to get deferred in terms of recognition even more so until they get to our doorsteps and have a blood pressure of 200 because they came in, as secondary prevention now as opposed to primary. So really important of screening, importance of that screening and advising that at a population health level, but also obviously amongst our patients that we provide care. 50% of people that are 50 will have hypertension. And that number only increases over time. As you get older, I think by 75, it's almost like close to 100% of people have high blood pressure. It's one of those things, if you live long enough, you're going to get it, right? Like it is one of those diseases of privilege, I guess, because if you're going to die at 20, you're not going to get it. But I mean, if you live long enough, you're probably going to get it. How are we doing? Well, I'll provide a little bit of evidence. So this is a study called the PURE study that, as a side tangent again, this is something that when I was a medical student, or I guess even before medical school, spent a year doing the actual anthropometric measurements and waist-hip ratios and all this fun stuff. And as full circle, I'm now the local PI of this particular study in Ottawa, having taken over from Dr. Weigloss. This study from 2013 actually looked at about, and the study has about 150,000 patients that have been enrolled as a cohort study aged between 35 and 70 across now 30 countries and with over 500 or 600 sites. And that's even grown further, as in we would be one site in Ottawa out of many in Canada. And what they interestingly found in this particular study is that of their total population, which included 150,000 patients, of which something like 60 to 70,000 were hypertensive, these are massive numbers, only 46% of these individuals even knew they were hypertensive. So as a part of the study, as I said, I'm measuring anthropometric measurements, I'm checking blood pressure, etc. When they were doing the surveys of these people, do you know you have a diagnosis of hypertension? Less than half of them knew they did have a diagnosis of hypertension. 40% only were treated, and almost, 10% only of that total population was actually controlled. Their blood pressure was actually controlled. And if you say, okay, well, what if we just focus on those people that are aware of that diagnosis and were started on treatment and really narrow the denominator a little bit? It's still only 32% of people that were on treatment that were actually controlled and at target. That's a big screw up. Like there's something wrong going on here, not just low. And again, I'll present some data about how things are in high income countries, which includes Canada. But at a global level, we are doing horribly in terms of the assessment, the awareness, the initial treatment, and then of course the actual management of this condition. This is one of their table 2, looking at differentiation between high, upper middle, lower middle, and low income countries. And obviously Canada, which provides probably 60 or 70% of the entire high income country data. So you can kind of look at that in terms of more analogous to kind of what we would think about. So in that population, you have about 6,000 people that were hypertensive. And of those, half were aware and 46.7% were treated, and only 19% were controlled out of that total population of 3,000, of that total population of 6,000. And if you just look at the people that were treated, that number is 40%. We wouldn't take this as being appropriate in any other condition. And I often stand up here in other sessions and talk to you about how terribly we do in terms of smoking cessation, best available treatment options, 30 to 40%. And even when we have literally hundreds of medications for blood pressure control, we're reaching 40% in terms of people that are actually managed. I don't think hypertension management personally is very hard, but I think it's just a matter of that ongoing follow-up and maintenance of that primary care and somebody's just regular touch points. And for that reason, I think we're very lucky. And I would love to come back next year and present our data from the Heart Institute, because I'm confident that not just as an institution, given the care that we provide, but certainly in the hypertension clinic, these numbers, we would blow those out of the water. So what are the challenges? I think often I kind of alluded to some of these. Well, it's often under-recognized and it's often undertreated, and that could be for various reasons. Like if you in Canada we have less of these issues, but if there's a lack of access to medications or lifestyle programs, or maybe you have inertia where somebody's like, oh, what's your blood pressure at home? Oh, it's 120/80 on that one machine that was like 15 years ago that you did. Oh, okay, yeah, it's his white coat. Don't worry about it. Like, I don't think that's sufficient, right? If you have somebody who's screening positive in clinic, you need to take another step to make that diagnosis, initiate treatment if appropriate. So if we're not actively escalating therapies rapidly, then we're not going to achieve target. And we'll happily share about one of the research studies, which is a randomized controlled trial, looking at that specific question, which will hopefully, once showing positive outcomes, will become a part of standard of care. There is that issue of adherence, and I will say that the number of people that I have that have 10 plus allergies that are in my hypertension clinic is growing by the day. You know, I appreciate that some people have intolerances or allergies to these medications, but unfortunately that results in them stopping these medications at the 1 year mark. What we need to do as clinicians, as care providers, as well as their primary care team, is to ensure that we're continuously following up on this topic. Because as I said, in terms of attributable risk, it is actually the most important risk factor for cardiovascular disease. There are other aspects as well to consider. Like if you happen to be working 3 jobs in extremely stressful environment, not able to cook fresh food or afford fruits and vegetables and eating fast food, you know, there are social determinants of health that affect whether or not you're going to be successful in controlling your blood pressure. Even access to care, right? We've got people up in Nunavut, which we're very fortunate, again, to have the privilege of providing care, but intermittently every 6 weeks or what have you. And frankly, hypertension is probably not the highest on the list of providing that type of care because of the other needs that they have. So, you know, this is, again, one of those things that requires that motivational interviewing and counseling and initiation of treatment. That is a part of everything we do to engage and enable change behavior. So, I'm sure many of you have seen this. I just want to put this up, and it's primarily, and a lot of the stuff that I'll be talking about today will be represented from the hypertension guidelines from Hypertension Canada, published in 2020. I believe an update is about to come up in 2025. But the long and short is that there are different ways to make the diagnosis of hypertension. So you could have somebody who says, hey, I'm at home and I use my mom's blood pressure machine. I checked it at home and I've checked it multiple times in the last week and it's continuously high. It's above, at home, let's say, oh, it's 140/90. And you're like, okay, well, the cutoff for home is 135/85 on multiple readings. We're going to need to inquire about this further. So the reason I mention this is because if you look at this diagram, depending on kind of where and what you're doing, the diagnostic criteria are a little bit different. I don't want to bore you with this because the issue is we don't need to complicate the situation. If your blood pressure is over 140/90 at any point, we should probably just make sure that we follow up with that and make sure it doesn't get worse or is not actually something of significance. And if you happen to come into the clinic and say, oh, I was just stressed finding parking, which I'm sure all of us can appreciate and I'm sure we can relate to, but the reality is, if your blood pressure is over 180, there's only so much stress that we can attribute here before we say we need to inquire and work this up a little bit more than just saying, oh, okay, you know what, the parking was long. I walked in and saw the lineup. And so if somebody has a blood pressure, single reading over at any point of over 180 systolic or diastolic over 110, that's diagnostic. You've got hypertension. If they have diabetes, 130/80 is the cutoff, and whatever way you want to test it, right? So typically the easy thing is if you're seeing them in clinic, you're probably going to say 140/90. If it's at home, 135/85. And then the 24-hour blood pressure monitors that we're often reading is 130/80 because now you are incorporating while they're sleeping. You're getting nocturnal readings, 8 to 10 of them at night. And so the cutoff is a bit lower. But as I said, the simple thing, you come across somebody, blood pressure over 140/90, or either one of the other, that should result in you saying, okay, well, we need to do this as an additional reading or remind the family doctor in our message to say, please follow up on this. And the reality is that it is possible that they may have white coat hypertension. And we see this all the time. And I'm guilty. I'm wearing a white coat. I do love the pockets. Like, I don't know what to say. I can hold my pens and my phone. But the reality is that if that is the case, we need to then say, take your cuff at home or go to the pharmacy and check your readings on a regular basis. Alternatively, you can say 24-hour blood pressure monitor at the Heart Institute. That is something that is offered, even at the TOH that's offered. So it's all to say that that would help you confirm the diagnosis. What I don't have on here, so we've talked about regular hypertension, we've talked about white coat hypertension. We've had some people that come to us and say, my blood pressure at home is super duper high, and then I come to you guys and it's completely normal. And in some cases, that's just because their devices are really old and they're not working, or maybe the cuff is too small and what have you. But sometimes they may have masked hypertension where they may actually have high at home and normal in clinic. Don't ask me the pathophysiology about that. But I mean, the long and short is that we would need to inquire about these cases as well. So how do we measure this? And as I said at the beginning of this session, I'm not 100% on this, right? As in, like, I think it's important and I know the studies and like, there's a study that was done in the last year that showed even just simply resting the arm on a chair versus them kind of holding it down can change your blood pressure reading by up to 10 millimeters of mercury. That may be the difference between like you treating or not treating. But the reality is that we need to make sure that the cuff size we're using is appropriate. And I have to admit that's often the gestalt, and I'll look at the arm and say, that's a big arm, and that's like my arm, and we need to use a bigger cuff or what have you. But these are some of the measurements. And typically you want to leave about an inch above the AC fossa. And that means that if you're going to be doing it manually, which actually I had to do 2 days ago on a patient because the cuff just didn't fit based on the type of cuff that we had, then you want to be able to measure that and listen to the cortical heart sounds. You do want them to be sitting for 5 minutes, seated on with their feet on the ground, their legs are not crossed, their backs on the. Now, if you're seeing 20, 25 patients, as we're often seeing, I don't know if we frankly have the time to have them sitting for 5 minutes unless you have multiple rooms that enable that and you have staff that are able to do this. So the reality is that implementation of something like this, while we appreciate that is important and affects blood pressure, becomes challenging in a busy environment. And we need to just be cognizant of that. And if we're seeing certain numbers, I might say, okay, well, you're at 138. I'm not too fussed about that if you don't have any other indication. They shouldn't be talking. Like sometimes I was in clinic the other day and they're like bending over to show me their legs. And it's like, okay, if the cuff is going off, you definitely can't be moving around. You can't be going up and down and you shouldn't be talking. That is something we can often kind of tell people, okay, while the cuff is going off, we're going to hold off on talking. And ideally there should be multiple readings. So at least we should be doing 3 readings, ignoring the first one. And ideally we have BP True, which can do up to 6 readings, and that automatically ignores the first reading. But the cutoffs in clinic would still apply of 140/90. What are we doing in terms of basic investigations? Well, one would hope that by the time they're coming to us for some other reason at the Heart Institute or what have you, they would have some basic blood work and basic work. But if they don't necessarily, then we would just get usual things like lights, creatinine, urinalysis, glucose or HbA1c, lipid profile, and ECG. And these are relevant because they actually, obviously, as in the case of diabetes or CKD, affect what target we're going for. So we need to know this information. But it also affects the medications we're using. If somebody has extremely low potassium, as an example, due to some sort of a secondary cause that we'll get into a little bit later, probably not the best person to put on something like a thiazide diuretic or a Lasix, which is only going to cause them to lose even more potassium. So we do need to know some of these things before we get really aggressive with our treatment. The lipid profile is really important as well, and that's more from a prevention standpoint. Like the reality is that many of these patients probably need to be on a statin, and so we just need to make sure that we're actively providing that type of care beyond just the blood pressure. And then in ECG, you can look for LVH, you can look for conduction disease, and other stigmata of the negative effects of hypertension. When do you order a blood pressure monitor? And I'm very fortunate to have taken this on at the Heart Institute. But it's all to say that there's not too many cases where we should be ordering 24-hour blood pressure monitors. Like in my case, because I'm often getting a lot of diverse, different, referrals for different things, then it's a little bit higher in terms of the number of orders. But if you happen to come across somebody who's got very labile blood pressures and you're like, okay, well, I don't really know, should I be treating you? Should I not be treating you? That's a good person. White coat hypertension, where they come to you with a bunch of readings from home and say, look, I'm kind of like borderline at best and certainly not high, but in clinic I go high. Well, you could get a 24-hour blood pressure monitor. Maybe their machine, you may want to calibrate, you may not have time. We can certainly arrange for a 24-hour blood pressure monitor. You may want to just say, I want to assess the response to treatment or adjusting the timing of meds. We're going to talk a little bit about timing of meds as well soon, but I mean, you might say, I want to know when the blood pressure is highest or lowest, and I'm going to start putting my meds accordingly to make sure their peak from a pharmacological standpoint goes higher when they're higher. And you may choose to do that, and I often do this as well myself. Alternatively, sometimes people say, you know what, I'm just too dizzy with your medications. I feel like my blood pressure is too low, et cetera, et cetera. I want to stop. And I'll say, hold up, before we start doing that, let's just do a 24-hour blood pressure monitor to confirm that you actually do have hypotension. What if your blood pressure is still super high? We can't just blame the drugs or your blood pressure for this, right? So you're not naturally just my body's at 180. Like, no, that, your body needs to get used to 120, 140. Like, we're not just going to say, that's just who you are. You're just natural. No, like, there's no concept of that. We know that this is harmful for your health. And then, of course, if somebody has nocturnal hypertension, you're going to benefit from getting a 24-hour blood pressure monitor in those cases as well. So moving on to the management. So, there's a few things as it relates to diet. So we're thinking about the usual thing. The DASH diet is probably the most well studied in the context of hypertension, where there's a focus on low salt, but also people forget that there's also a focus on other things like fruits and vegetables and whole grain and rich and high in fiber, protein from plant sources. And there's also studies that have been done, although I have to admit, full disclosure, I see that listed there and I'm like, I didn't put the study in, but there are studies that show even potassium supplementation can significantly improve blood pressure control as well. So these are some of the things that we'll talk to them in the context of their hypertension to help them manage their diet a little bit better. There's also exercise, and again, this is kind of, and again, we have Emily, who's actually here, is a superstar, fitness person, but also a fellow in hypertension care and nephrology. And, I always have to kind of think about the idea of saying, okay, well, ideally, I want you to do moderate exercise, 30 to 60 minutes, walking or jogging. You can still hold it, you can't say your full sentence, but you can say a few words before you're like huffing and puffing. You're not like about to bend over and like fall and go to, pass out. But I mean, there's also some people that we see who are like hardcore bodybuilders. And, in those cases, we actually find their blood pressures are higher. And again, so often what my advice is, okay, like, you might want to do lower weights, more reps. However, that is an area that requires additional assessment as well. But in general, we'll say, okay, aerobic exercise we know is going to be helpful. Now, taking a step back, because I forgot to mention this at the beginning, all of these lifestyle management. So let me get a vote here. Each of these, how much do you think that they can reduce your blood pressure if you are compliant with them? So we're going to say 1 to 2%, close to 5%, more than 5%. Where do we think? So we'll say 1 to 2%. In terms of if you were to comply with these lifestyle management, how much would your blood pressure improve if you were compliant with this? By how much would your systolic blood pressure drop? Well, 20%, 8 to 10, these are great now. So we've got 5%, 8 to 10, 20%. So, if each of them is dropping you by that much, it might be a little bit tricky because then we might never need any drugs. But I mean, just to be reasonable, it's about 3 to 5% each of them. So if you're able to go and do a salt restriction, you're able to reduce your blood pressure by 3 to 5%. You exercise on a regular basis and you didn't before, 3 to 5%. And weight, if you're able to lose weight, something like 10 pounds weight loss is approximately 3 to 5 millimeters of mercury. And when you think about it, the easy number that people often will quote is for every kilogram you lose, which is about 2.5 pounds or so, you're reducing your blood pressure by 1 millimeter of mercury, right? So just to give you an idea, and these are all things that go together. They're not like, oh, you did 3 of them, so you're only getting 3 for 1. No, it's like all the benefits of the 3 of them you're going to get. So we do actually focus and spend a lot of time in our clinic going over lifestyle changes because these can have a true and important, meaningful impact in their blood pressure. And for some people, they don't want to be on 15 medications, right? So if we can avoid some of them by focusing on lifestyle changes, that's an important aspect of our job as clinicians. So as we think about maintenance of body weight, I'm fully cognizant that BMI is not the ideal measure of body weight and what have you. However, it's a crude estimate that we tend to use, and ideally you want them kind of in that normal range, quote unquote, of 18.5 to 25. We also do measures like waist to hip ratio or waist circumferences, and those can also certainly be a marker of central adiposity. But the reality is that if they happen to be somebody who is outside of these ranges, we're often talking to them about the importance of weight management and strategies, which we can't just come in and say, lose the weight and I'll see you in 10, like in a year. Like there is a component again of motivational interviewing and change management. And now we're very fortunate to even have pharmacotherapy to support people to lose weight. But again, it is a multidisciplinary approach. And again, we're very fortunate at the Heart Institute, led by actually Jennifer Harris, who's in the back, and many others in the committee that we have in prevention, rehab, and obesity, where there's actually a quality improvement project to do the 5 A's in obesity, and identifying these individuals and making sure that we advise them, initiate treatment, and follow up, and what have you. So exciting things that will hopefully be coming up in the coming year as well in terms of management of ideal weight at the Heart Institute. Stress, all of us are stressed. I don't even want to look at my, watch in terms of what my heart rate and sleep was last night. But I mean, the reality is that we're all stressed. But I don't necessarily focus too much on that, frankly. I have to say, like in my notes, for anybody who's ever received a note back from me from the hypertension clinic, I'm not necessarily focused on what is their stressor. I'm more focused on what are your stress management and coping strategies. What do you do when you're stressed? All of us are stressed. There's no question about it. But what do you do? Oh, I go play with my kids, or I go out for a walk with the dog, or I go for a walk, or I go to the gym. Whatever healthy mechanism that we can get for them to be coping positively with their stress, that's kind of what we need to focus on and move them towards. Um, and again, like, relaxation and mindfulness and spirituality, these things can be very important for many people that have high blood pressure, among other things. And then I'm not going to go into this. I'm not going to belabor the point. I don't want to seem biased talking about smoking again. But I mean, frankly, if alcohol, smoking, recreational substance use, we need to make sure that we're addressing that, because those are very important causes of high blood pressure. I'll give you an example. So I have a friend who I played cricket with for most of my life. He called me in like a panic, and he said, I need to talk to you like urgently. And I'm like, it's 11 o'clock. So he's like, my blood pressure is like 180. And I don't really check my blood pressure, but it's super high. And I'm only like 32, whatever. And I'm like, okay, just, I'm not providing any medical advice, but what were you doing in advance of you checking your blood pressure? Like maybe you were weightlifting and running and sprinting. And he had been using hookah or shisha, which is like the water pipe, for like an hour or two, literally like 30 minutes before he checked his blood pressure. And I'm like, okay, well, there's a lot of, especially with certain types of water pipe, they have nicotine in them. So maybe there's a stimulant based on that. Checked his blood pressure the next day, completely normal. Disaster averted. Didn't start any medication or need to start any medications. But yeah, these substances have a huge and important impact on blood pressure, and we need to be mindful of that. And again, we should be telling them to abstain from these substances. We all need to also review the medications in terms of the medications that are often associated with increased blood pressure, but the ones that we're often commonly known to avoid from a heart perspective is things like NSAIDs, steroids, of course, if anybody's on that, but even oral contraceptive pill. Like often I'm referred young women who have high blood pressure. And I have to say, as a side tangent note, like I'm not trying to put the diagnosis of hypertension. It has implications on life insurance and disability insurance. So I'm often finding any of these quote unquote situational reasons to explain hypertension, or any of these modifiable reasons, then we can say actually they don't have essential hypertension, so they can get their usual life insurance and disability insurance, what have you. But when you have oral contraceptive pill, especially when it's not just single hormone progesterone, but progesterone and estrogen, that actually increases your risk of having high blood pressure as well. So sometimes we'll say switch off of your combo hormone pill and instead go to progesterone only OCP. So again, there's several different lists. Licorice is always listed in there, and I don't think I've ever seen personally. Maybe others have here, but I've never seen it. But there's other things that can also cause this as well that you want to be mindful of, whether medications or substances or other things they may be consuming. Natural or herbal medications, again, on our consult, we ask every single patient about natural, herbal, over-the-counter things to hopefully catch this. It's not perfect, but we do actually ask them in detail what different supplements they're taking and whether they may be contributing to any of this. So in terms of targets, like I just plugged this in, we're going to go through this one by one in a bit. This is from the Hypertension Canada guidelines. But in short, if the reality is that if somebody has, we talked about the 140/90 on multiple occasions, or if somebody has high blood pressure with cardiovascular disease over 130, even diabetes over 130, et cetera, we're typically saying we're going to be starting you on treatment. And your targets for treatment depend on your underlying condition. Now, at the Heart Institute, again, we're very lucky. It's pretty easy. Most of our targets are going to be less than 120/80 because they're going to meet sprint criteria in many cases, unless they're diabetic, in which case they're going to be less than 130/80. In those that have peripheral arterial disease, it's kind of similar, but you need to be a little bit careful about how aggressive you are. And we're going to talk about that in a minute. And you might wonder, what is considered high risk of cardiovascular disease? And this is some of the SPRINT criteria. So people who already have cardiovascular disease, of course, in our patient population, chronic kidney disease with certain markers as well, Framingham risk of over 15%, age over 75, which I'm always a little bit like, oh, I don't know about that. But it is on there. And then if they have some other sort of condition, if they have one or more of these, that you would consent to in intensive treatment. So, you're actively looking for these. But again, for our patients, we're often already met the criteria. Many of them have heart disease. And as I said, this is based on the SPRINT trial, which is now 10 years old. It doesn't seem that long, although I was in residency at the time. But I mean, this is almost 10,000 patients of those that are 50 or older with hypertension and some sort of high-risk feature of cardiovascular disease, but no diabetes. And they looked at targets less than 120 or less than 140 with a median follow-up of 3 years. So looking at among many other outcomes, but their primary outcome was a composite of MI, stroke, heart failure, cardiovascular death. This image over here, hopefully you can see my mouse. Yeah. And that looks at how actually successful they were in achieving their blood pressure control. So you see that in the standard treatment arm, you're kind of in the 130, 140 range. And you look in the intensive treatment, you're kind of around that 120 mark. And what they see is, if you can focus now on the primary outcome, is that the hazard ratio is like, 0.75, significant. You can see the lines kind of break off, and even death from any cause, again, similarly, hazard ratio 0.73. And again, the lines split off pretty nicely. And so pretty much what they concluded, and this was a landmark trial in the context of hypertension, that anybody who's high risk for cardiovascular events without diabetes, targeting less than 120 resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. That's not to say that they didn't have issues, right? They had electrolyte problems, they had hypotension, et cetera. So that's where individualized or quote unquote precision medicine comes in, where we're going to talk to our patients and say, okay, we got you to 115, but you can't get out of bed because you're too tired. Maybe we will back off on some of your medications at this time. So, again, but this is kind of what the trials and evidence show. And for those that can tolerate it, we will try to hit that target of less than 120 over 80. Now, just thinking about the general population, and there are different subpopulations within hypertension, and that affects whether their blood pressure cutoffs are higher or lower. And again, we see a variety of cases at the hypertension clinic, but most of us, when we're seeing them in our general cardiology clinic or other clinics, they have some other indication from a heart side of things to target that 120 over 80. But if you have no other compelling condition, then pretty much what we say is your target less than 140 over 90 in clinic or 135 over 85 at home. And usually the first line medications are any of the following, and they're kind of in just alphabetical order. I don't have, I think as I mentioned in disclosures, I don't have any particular disclosures, but I mean, usually in many of our patients, ACE inhibitors are often being used. So any of these drugs are considered first line therapies for hypertension for those that do not have any other particular compelling indication for a drug. If you've tried these and you're on maximal doses of all three of them, the next best drug would be the spironolactone, based on the pathway study, which looked at spironolactone versus beta blockers versus alpha blockers, and found that spironolactone was superior to those. And then we were chatting about this earlier before rounds, but combination therapies can actually be quite helpful in terms of compliance. But the reality is, if your patients don't have a drug plan, they may not be able to afford it. And the difference, and maybe Lynn can speak to this at some point, but the difference can be a factor of 10. Something that might be 10, maybe 30 cents turns out to be $3 per day if it's a combination. But it can help with compliance, and compliance is the name of the game in managing hypertension patients. What about those that are diabetic? I should probably put an asterisk here. I see some people, including Aziz and Daruv, who are working on a systematic review with me on this particular topic. But all to say, right now at this time, the target is less than 130 over 80. This is based on the Accord studies that have been done. But now people are relooking at that stuff and saying, well, even in the Accord trials, the people that had normal glycemia and intensive blood pressure actually had much better outcomes. And so there's actually been 2 studies since that time, literally in the last couple of years, that have looked at intensive blood pressure control in diabetic patients and found improvement in outcomes. And so we're hopefully, systematically reviewing and meta-analyzing that, and hopefully you'll be submitting that in the next month or so. But if you have diabetes, ACE or ARB are your first line treatments, followed by the other ones. What about CKD? frankly, we have a very good relationship with our colleagues at TOH, which is a nephrology hypertension clinic. So if people have significant CKD, I'm often reaching out to them for guidance, and vice versa if somebody has cardiac issues. But again, eventually there are overall target can range between less than 120/80 because of the sprint study, but also in some cases, as I put here, it may just be less than 140 if there's not a lot of those other factors like the proteinuria. And again, ACE and ARB are primary first line. So then you can imagine, when we look at some of our prevention and rehab data, patients come to cardiac rehab clinic and like half of them aren't on ACE inhibitors. This is like class 1 indication. Pretty much anybody with a heart who has any heart issues needs to be on some form of an ACE or ARB. And that's probably another idea for QI that could be considered looking at prescription practices of ACE and ARBs at the Heart Institute. Okay, I'm just going to admit this person. What about stroke? Again, there should also be an asterisk here. Of course, if you're on Team Orange and managing somebody who's in the stroke unit who's just had a stroke, this does not apply. We're talking about stable outpatient individuals. Usually you're targeting less than 140/90, and some people may even suggest being more aggressive at 120/80. But of course, in the acute setting, there is permissive hypertension, and we're not going to get too aggressive in that case. And again, in the context of ACE inhibitors, specifically, there's quite good evidence for perindopril in that population, and that's the most commonly used ACE inhibitor for those that have stroke among our neurology colleagues. So you're often using ACE inhibitors and thiazide diuretics, and then followed by other medications. And CAD, I think we all know this already, ACRB, beta blockers if they have any sort of angina or heart failure. Calcium channel blockers, you can use things like amlodipine, but non-DHPs like Dilton, verapamil, you obviously want to try and avoid, and certainly in those that have reduced heart function. And thiazide diuretics you can, of course, use as well. And there's other forms of diuretics that can be used. And I tend to avoid combination of Lasix with other thiazide type diuretics. Like we probably use one diuretic and leave it at that. What about PAD? So a few of us were actually privileged to be a part of this guideline for CCS on PAD, and I was actually tasked with writing the hypertension section on that particular guideline. And so in terms of patients with PAD, often they'll have differences in blood pressure. And so if that is the case, sorry, we can't go based on this low number and be like, yeah, you're fine. We'll check the low one every time to make us feel better. We actually have to go based on the high number and titrate your medications according to that. And typically in patients with PAD, after a thorough literature review, we said we think it's somewhere in the range of 120/40, between 120 to 140, and the diastolic between 80 to 90. Like, it's kind of a bit of a range. And the reason and the choice of drug, again, based on the HOPE studies, was looking at ACE inhibitors and specifically in ACE inhibitors, but there's studies, of course, of ARBs. The reason for that and for why we don't just say everybody should be less than 120, even though these individuals were part of the SPRINT study as well, is that when you get blood pressures less than 110 among those that have PAD, there's actually a bit of a J curve where you start seeing worst outcomes as it relates to MACE and MALE. So you want to, which is like major adverse cardiovascular events or limb events. And so you need to be a little bit cautious about that. In terms of, this is often a question that I'll get about timing and, whether we should give everybody nighttime drugs, and will that be, the magic bullet for our patients with hypertension? Well, that's coming from something. So this is a study that was presented at ESC and then subsequently published that looked at whether you give the medications one or more at nighttime or you give it the first thing in the morning. They had almost 20,000 people that they randomized for this particular question, and the follow-up of up to 6 years. And they, again, were looking at composite cardiovascular outcomes of heart attack, stroke, heart failure, and cardiovascular death. And what they found, I've copied their conclusion like verbatim on here, routine ingestion by hypertensive patients of one or more prescribed BP lowering medication at bedtime as opposed to waking results in improved control and major cardiovascular events. And this is their forest plot of the hazard ratio. Total events, very far left shifted towards giving it at nighttime. CVD outcomes, very far shifted, like a 45% reduction. Like, I don't know much in life that does that. Like, that is humongous in terms of the effect that it had by just changing the timing. It seems a bit too good to be true. And again, everything is left shifted. However, unfortunately, and this remains, is that the trial then because it was so hard to believe, they actually had to put a notice or expression of concern about the study itself, about whether their tests were the results were reliable. And if you go even now to the study page, you'll find the editors would like to inform the readers the content of the conduct of this randomized controlled trial is currently under investigation. And then they add some other stuff like you need to be careful about looking and applying any of the results of the study. Now, that's relevant because there's another randomized controlled trial that's 21,000 patients that also looked at this question, published in 2022, this one in Lancet. And this one, again, looked at morning versus night with a median of 5 years and primary outcome of composite CV events. And there's no significant difference in this one. So, it's not really making sense. So based on all of this, patients often ask me, colleagues often ask me, do you tell patients to take blood pressure medications at night? I just tell them, I tell my patients to take their medications whenever they think they're going to remember to take the medications. If it's going to be at noon at lunchtime, take it at noon lunchtime. You think it's going to be morning before you brush your teeth or after you brush your teeth, do it then. Nighttime, whatever we can ensure compliance with is when we would like for them to initiate their treatment. I'm going to remove this. So what about in hospital? So this is another question that we get asked about is like, okay, blood pressure is 140. Should we start them on treatment and things like that? And again, as we discussed, blood pressure can be quite situational, and the targets in hospital actually can often be more liberal because there may be other reasons why their blood pressure may be higher in hospital than they may be otherwise. So unless we're talking about a hypertensive emergency or urgency, we don't need to get too aggressive when somebody calls you overnight and says blood pressure is 142 or 150 or something like that. You want to do something about it, especially in asymptomatic patients. You actually need to be a little bit careful about not being too aggressive because you may actually result in AKI and you may actually affect diastolic filling of the coronaries, especially among our cardiac patients, which can result in some myocardial injury. And there's multiple studies. I've just put up one of them that was published about 5 years ago that demonstrated this. So shifting gears a little bit in the last 10 minutes or so, resistant hypertension, this represents about 5 to 10% of your cases. And typically we'll say these are patients that are not achieving their blood pressure targets despite being on 3 of the first-line drugs at optimal doses. When you're going to suspect it in young patients and even in older patients, like if you've got that range of those that are less than 30 or over 50 or over 55 or so, you're going to start thinking about this. We're a little bit more liberal in saying even if you have somebody who gets diagnosed but less than 40, they might have had it unknown to them for even longer. So I'm happy to see them in hypertension clinic along with my colleagues. If they have severe hypertension and despite you're trying to use medications, there's still ongoing severe hypertension. Again, this is an important component to look at. Sudden worsening of previously stable blood pressure, maybe something has progressed that may be a secondary cause that we need to address. And of course, if there's signs of end organ damage, that may suggest like LVH, proteinuria, and retinopathy and things like that. So before we jump the gun and add 5 medications, we just need to make sure in those cases, is this truly resistant hypertension? And the number of times I've seen the 24-hour blood pressure monitor come back in a normal range, it makes me a believer, at least in its use for clinical for practice at that time. You want to make sure that you're adequately dosing. This is not, and I'm sure none of us are guilty of this, but not the starting doses of 3 meds. It's optimal doses, maximally tolerated, ideally. Assess compliance with the medications and lifestyle if you find that somebody appears to be resistant, and of course, consider secondary causes. In terms of secondary causes, again, just to quickly go through this, in our day and age, people often have echoes before they even see us. So the likelihood somebody's going to randomly walk in where the coarct is quite unlikely. But, if somebody you're seeing is young and you're unsure, peripheral pulses, murmurs, and assessing blood pressure. And if you're suspicious, we should be getting blood pressures in the legs as well. But an echo is going to make that very effective in terms of diagnosis. The most common cause that I see and most people see in their clinic is sleep apnea. I would say half the people I see for secondary hypertension who actually have a secondary cause have sleep apnea, and the other big chunk is hyperaldosteronism. And so pretty much every patient that we're seeing, we're asking in hypertension about their sleep. We're calculating stop bang, whether we stick that in the note or not. And then if it's 3 or more, so intermediate risk or higher, we're often ordering sleep study. The sleep medicine clinics are very familiar with Melly and I because we send so many referrals for sleep studies. And I will say again, I'm surprised at how likely they are positive, which makes me worry as to how much we're missing in terms of these patients and their OSA. Renovascular, so if they have any two or more of these, so if they have sudden onset worsening, some of the things that we've already talked about in the resistant hypertension thing. So of course, if they have bruits, if they're resistant to 3 drugs, if you start them in an ACE or ARB and their creatinine jumps by more than 30%, other ASCVD risk factors, recurrent pulmonary edema, then you're going to consider these types of causes, which can start off with a Doppler, CV Doppler aorta/renals, but often we're doing CTAs and MRAs in these patients. And of course, if it's confirmed, then again, often we have partnership with our TOH colleagues who support this, but then they can consider angioplasty in such individuals if appropriate. Fibromuscular dysplasia, again, if they have any one of these following, so if they have different kidney sizes, because again, we're getting ultrasounds or imaging of their belly, abnormal bruit without any obvious atherosclerotic disease in terms of their testing. If somebody else has FMD in their family, or if they have FMD that's known in some other body part of their another body part, then again, we're going to do additional workup with a CTA or MRA, and then if they are confirmed to be found this, we want to do CTA MRA of other vascular beds and also, of course, rule out intracranial aneurysm as they can be associated. In terms of endocrinological causes, and again, I just put the most common ones up here, just very bare bones. I'm not expecting everybody here is going to do much more than this, but just in terms of screening, most of our patients have TSH. If you're wondering about Cushing, especially if they have the features that somebody of that may have Cushing's may have, we're often doing ACTH and cortisol, and we'll often do a dexamethasone suppression test. So you'll see that and you'll say, oh my God, the cortisol levels are so low and ACTH is so low. We'll give them 1 milligram of dexamethasone that they take at 10 p.m. the night before, and then go get their blood work the next morning. And if their parameters are suppressed, then they do not have Cushing's. If they still have high levels of cortisol or ACTH, then we think about where the Cushing's may be coming from. As I mentioned, hyperaldo, probably the second most common thing that I see. We're often ordering a renin and aldosterone levels if they're above 144 based on our tests in terms of the ratio. That would be a significant finding, often referring to Dr. Hundemir, who's the expert in Ottawa relating to hyperaldosteronism. And then FEO, again, if you have the right history, somebody who's having labile blood pressures, kind of like, rapid ups and downs and having those flushing symptoms and what have you, then often we're screening with urine metanephrines as well. But again, often people come to me and their question is this, and so I'm liberal in terms of testing it more often than not, so then I can give the answer to the person and the providers. What about in terms of the aldosterone-renin ratio? Well, this is what can happen with certain medications, and the long and short is the medications can affect your renin and aldosterone levels. The most important medication, obviously, is spironolactone, because that's really going to affect the results and throw your results out of whack. The other ones, they may sometimes result in either false positive or negatives, and the false negatives, if you're still positive despite being on these drugs, it's like you definitely have hyperaldo at that point. So I've just added this as a reference as well. What about other situations? Again, I'm not a pregnancy expert, although I do see a lot of patients that are either pregnant or postpartum. And they may be, people that had normal blood pressures their whole life, and after 20 weeks of gestation, they find that their blood pressure increases. Well, that would be considered gestational hypertension. And of course, those that have preeclampsia, who have hypertension and proteinuria, who are being assessed for this. And the typical choice for those that are pregnant would be calcium channel blockers like nifedipine, labetalol, and then methyldopa, which have the most evidence, and we're often prescribing these medications for our patients. Things like ACE, ARBs, MRAs, and diuretics would be contraindicated in those people. Last couple of slides. So in terms of renal denervation, so this is something that is up and coming. There's actually been several studies in the last 5 years. Again, we have colleagues at the TOH who are quite interested in this, and I think Derek is online here as well. And we had a kind of a three-way email chain discussing renal denervation locally, but it is a minimally invasive catheter-based procedure, radiofrequency ablation to the sympathetic renal nerves around the renal arteries to reduce sympathetic drive and fluid retention, and typically performed by interventional, either radiology or cardiology. But we do need to be selective. These people are truly people who are unable to tolerate medications or have resistant hypertension, and are either unable to get controlled despite best available treatments or unable to tolerate, and we may consider renal denervation in those individuals. So last couple of minutes, I just wanted to give a huge shout out to our team at the Heart Institute at the UH Hypertension Clinic. As mentioned, myself and Melly have been the physicians looking after these patients, and Dr. Heshka will be joining very shortly. We have an outstanding administrative assistant, Anita Pa, who's been instrumental in organizing us and providing updates about wait times and things like that. We've got our nurses, Madison and Stephanie, who do thorough assessments. So when you see my note, you'll often see an even longer and better better note a day before or a week before, that's often our colleagues in nursing. Zandra, who's like the lifeline of this clinic, she's our APN, and she really keeps us in check and often, very, very on the ball, making sure that if any issues need to be dealt with, they get dealt with. And then Emily Serrano, who's also superstar in the world of smoking cessation, but has been involved in hypertension, providing coverage as an APN, and has been extremely effective and supportive. And of course, we have Bonnie, who's the director of prevention and rehab, and of course, from administrative support that she provides and ensures that we have the necessary resources to deliver the care that we do. And I'm very proud of our team and thankful to them. Our particular criteria, I think we talked about it. We're often focusing on people who are resistant to hypertension. And so, if you have any patients that have this, you suspect secondary hypertension causes, you have difficulty controlling them, maybe they're pregnant, or they have heart disease and you're not getting them controlled, we're happy to see them. And then the process, typically, as mentioned, our nursing colleagues are seeing them, providing educational materials, doing 6 readings in both arms, and then standing up and doing 2 more to get very detailed assessments, usually at home, but sometimes in clinics. And then we have consultation workup for secondary causes, and then providing recommendations from myself and Melly, which hopefully will not just be dependent on us, but implemented by our colleagues who are referring us the patients and their primary care team. Last couple of things, we have a randomized controlled trial looking at patients that are hypertensive. If you have hypertensive patients, please feel free to send them, although we're almost done recruitment. We're randomizing patients to a telehome monitoring and management program where we monitor them using a specialized device that sends readings to Laura, who's our superstar nurse. And then we actually have a medical directive that titrates these medications every 2 weeks. So we're finding really fantastic results here, and the results hopefully will be available by the end of this year, but we're seeing 10-15 millimeters of mercury difference on 24-hour blood pressure monitors in 3 months of intervention. So, we're finding that this is we're hoping that this will bear out. We're targeting 100 patients with 24-hour blood pressure monitors at 0, 3, and 6 months. And hopefully, as I said, we'll get to the completion of the study by fall of 2025. We've already randomized over 80 patients. We also have some systematic reviews that are led by our own colleagues in cardiology residency with Daruv, Aziz, and others, looking at optimal blood pressure targets in diabetes. And then we have one that's looking at telehome monitoring for hypertension, again, to kind of go along with the randomized control trial that we are hoping to report this year. And then we also have, using the data from that randomized control trial, development of digital therapeutics like an app with AI and ML that would actually be used to support our colleagues in the care that we provide for controlling blood pressure. So I'll put my summary slides up here. I think we've gone through a whirlwind of hypertension and tried to summarize a big topic for you all, and welcome any questions that you might have.
Great. If there's a couple questions in the audience, maybe while I'm walking over, Hassan, can you comment on the cost of ambulatory blood pressure monitoring? Is it does it cost the patient or what have you?
Great question. So ambulatory 24 blood pressure monitor at the Heart Institute costs the patient about $110. In other sites, it is covered by the hospital, like at the TOH. I think they do non-stop 24-hour blood pressure monitors for their patients. If anybody has trouble paying for it, they'll often reach out to me, and at 100% of the times, I'll say I'm happy to defer the costs that relate to certainly anything that's related to me, but I'm sure even the institution. So if cost is prohibitive, then we say we're happy to waive it, but we don't advertise that publicly.
Excellent talk. I agree with your observation that number one, the blood pressure at the Heart Institute, at the outpatient clinic, one, the blood pressure is not routinely recorded. Two, even recorded, if frequently not properly done as you suggested. So my question to you is that what infrastructural changes that we can adopt to ensure that one is being done and two is being done properly?
Yeah, it's a great question and probably one to ask from administration. Well, I guess it's somewhat limited. There's an ideal world, and I know we were at the Hives and they're like, think unlimited money, unlimited space. In an ideal world, you have somebody who's entirely dedicated to measuring blood pressure in a room that's nice, calm, with calm yoga music or, massage music that's playing in there. They're sitting there for 5 minutes. They come in before their assessment with us, and that's already done by somebody. So by the time they come to us, it's done properly, and we know it's done properly, it's pre-populated in our node. And if there's a flag, we are sent a heads up, hey, you need to do something about it. That's in an ideal world. The reality is that we don't have enough, often we don't have space in clinic for routine care, let alone to devote something for this. However, when we have clinics, sometimes we will tag team. So we'll have one clinic room where the nurse will actively do the blood pressure readings in the appropriate manner, and I'll be in another room. And then once they're done their assessment and done the blood pressure reading, they'll bring it over to me. Frankly, it's very efficient, saves a lot of time. However, our nursing staff are absolutely wonderful, but there's a limited resource there. Everybody doesn't have that appropriate that access that we're very fortunate to have in hypertension clinic. So yes, that would be in an ideal world. If you would like that. Otherwise, we should also be telling, and as we're advocating it to the Heart and Stroke Foundation and the Canadian Cardiovascular Society, every patient, every household, and we're telling the government as well, every patient, every household needs to have a blood pressure cuff. It should never be the case that they don't have a blood pressure cuff, because if they do, then programs like the one we developed for that randomized controlled trial can be leveraged to provide remote care for individuals in titration of medications. So we should also be advocating all of our patients to get their own blood pressure cuff, teach them how to do it, and measure it at home and track that.
Hassan, apparently, according to Dr. Garuba, the TOH does not cover ABMP.
So the nephrology clinic at the TOH Riverside. Yeah.
Question from Dr. Budwani. What are your thoughts on blood pressure targets for patients with thoracic aortic aneurysms in the absence of other cardiovascular disease? And is there evidence to support this?
That's a really good question, especially, if it's just kind of like an asymptomatic type of a situation, to know what we should be targeting. And I'm personally not aware of strong guidelines that say what we should be doing in these thoracic aneurysm patients. Is the reality, I'll tell you what my personal practice is, and I can't say that it's heavily evidence informed or evidence based, is if somebody has an aneurysm, for me, that's cardiovascular disease. I'm targeting less than 120 in them, right? Now, is there strong evidence to support that? Probably not. But if somebody has dissection or other things, we're often getting as close to 100, 110 as possible. So that's what my personal practice is, but I'm fully cognizant that that isn't necessarily evidence informed in the context of, whether 140 or 120, but I target less than 120 in those individuals.
On the floors, the nurses measure blood pressure often, right? Like 3 or 4 times a day. So the hypertension guidelines, the Canadian ones, say twice a day for recommendation for measuring. Do you know the history of why they say do it before breakfast and after dinner specifically?
That's a good question. I'm not aware of that. Usually what I tell my patients is to get the blood pressure reading 2 hours after breakfast, after their morning medications, to get a better sense of kind of what their actual blood pressure is with that. I could make the argument, though, that if you wanted to get a sense of what their blood pressure is, especially if we're using daily medication doses that hopefully should be sticking around by the morning, you would hope that you're assessing the control right before you take some medication, so maybe along those lines. But my personal recommendation is 2 hours after they've taken their medication, so we can get a sense of kind of the ebbs and flows. But I'm also somewhat fortunate that we have access to 24-hour blood pressure monitors if we need, and I have my own as well as a part of my research program. So a little bit spoiled there, but I personally don't tell people to do it before medications, before breakfast. In terms of the number of times we do it in hospital, I think there are other indications for that, not necessarily for blood pressure alone, but often we're seeing that moving down to twice a day as opposed to 4 times a day. At least when I was on Orange, we were kind of being mindful of resource utilization. Yeah, Pascal.
Hey, Hassan, thank you so much. That was a very nice presentation, very helpful. My question is, how many patients would you estimate would be candidate for renal denervation currently that you follow?
Yeah, and again, this is something that we talked with the TOH group as well. And I think when we were chatting about this, I think he mentioned there might be one on his radar that he thought could be considered. Maybe, I can think about at least probably 5 in my practice that I could likely offer that procedure if that was available. Some, like I said, who've gotten 15, 20 medication intolerances and blood pressures of 180, and it's like, are we going to be palliative here, or like what's going on? You're not going on any meds. Every time I see you every month, you're off medication. So I think I do certainly have, I would say 4 or 5 patients myself, and I don't know if Melly, you can comment. Maybe one for Melly as well. So maybe at least at the Heart Institute we have 5 to 10, and I don't know, Emily, if you can comment at the TOH. Couple of patients. Yeah, exactly. Yeah, and I didn't get into the whole, honestly, it could be a whole talk on its own, but I mean, there's studies that show benefit, and then they did a sham control trial that didn't show that much benefit. And so that kind of cooled people down. But I think it would be fair to say between the 2 hypertension programs, there are probably about 10 people or so. David.
Dr. Burney, last question.
Excellent talk, Hassan. Is there any evidence that renal denervation actually reduces heart clinical endpoints? I know we get.
No, it's more so composites that we're typically dealing with in terms of blood pressure. But I think that's been one of the criticisms. And that's why even when we kind of mentioned in the slides, it's like very appropriate people who are not able to tolerate medications or get onto optimal doses. So it's, but we would think, and it's likely because of the fact it's procedural thing, it's addressing blood pressure, you may need a larger population with more events. But yes, it's based on blood pressure mostly, and about 5 to 10 millimeter reduction.
Thank you so much. That brings us to the end of rounds. That was excellent, Hassan. Appreciate you presenting today. Please join next week. Dr. Yoshida Godoya is going to be presenting on imaging and microvascular disease. Have a good week.
Thank you. Great. Thank you very much. Great.